Welcome everybody. This is great. I'm excited. We're going to have a great GI talk. Dr. Ruliak is with us. Have no fear. He actually raced down from Northgate through traffic, made it. Yay! So his topic is going to be a number of things GI related, including gluten. You've heard of that. FODMAPs, many of you know what that means. And the gut microbiome. That sounds very exotic, doesn't it? These are kind of very relevant topics to many of us and affect nutrition and energy and health in many ways. But first, not to let you down, I got a little show. Rue de Peak. Ooh. So we went to San Francisco in April for spring break. It's a lot of fun. I'm sure everyone's been there. It's been a long time since I've been there. I didn't remember how vertical the city is. Lots of walking. Oh my gosh, pedometer. And so we did a restaurant each night. This was the first night, kind of in Nob Hill, a couple blocks from our hotel. And I don't have photos because I felt it was such a private, small restaurant. I felt like someone's living room. I didn't want to whip out my camera. But it was beautiful. My family ate escargot with me. Wow, that was really exciting. Then we moved on the next night to downtown San Francisco, business district, a place called Roca Acor. Took me Roca, and Acor is Roca spelled backwards. I have no idea what that means. But it's a Japanese restaurant. It was such a spread. Oh my gosh. I think I needed a wheelbarrow to get us out of there. It was probably a 10-course meal, and somewhere in the middle of it was this gorgeous soup with mushrooms and tofu and scallions, and it was just divine. The presentation was exquisite. You just even didn't want to eat the food. Then, okay, we needed a hike. So we went off to Muir Woods National Monument, the Redwoods. Beautiful, beautiful place. And here's where it was interesting. You know, the three of us, my husband, my daughter, and I, had various ideas of what this hike was going to be. My husband said, well, we're just going to do that little loop trail, whatever that means, and see, you know, the Redwoods. And my daughter had another idea. So when we should have turned left, we turned right, and we kept going up and up and up. And an hour later, we were still going up. And we thought, this is not the loop trail. So it was actually really spectacular. We're really in the middle of everything. And we couldn't see for an hour where we were because we still weren't at the top of the trees, but it was spectacular. And we got really dusty and hot and hungry, of course. We hit a trail called Lost Trail. We thought, okay, we got to figure out where we are. So got back, and oh, this is the hotel. My daughter looks like Mary Poppins there. So excited that she's back and really having a good time. So the next restaurant that evening, we went to a place, my pick, called North Beach Restaurant, Italian food. Let me tell you how divine it was. I was so amazed. And actually not just at the food, it was good, the artwork. There were mural paintings all over the walls, and then the waiter said, oh, you should go down the back stairwell, and there were Salvador Dali's down there, and it was exquisite. It was so beautiful. So we dined among art. It was really lovely. And, oh, we had to go to Alcatraz. I felt like a total tourist. I was a total tourist. I swear I wasn't going to do those audio tours, but that was fascinating. The history was really incredible. And, you know, back in 1963 at Alcatraz, here was their menu, by the way. I had to take a picture. Assorted dry cereals, steamed wheat, scrambled eggs, 2 milk, fruit, toast, bread, butter. Oh, sounds so attractive. That's the anti-FODMAPs, I think. So we had to, of course, collect our senses and come back, and after visiting Girardelli Square and having you know what, and walking along the Fisherman's Wharf, we ended up at Mason Pacific, which is a really fabulous kind of modern California American fare, really delicious. And this was a morel mushroom with some actually dumplings and some peas and this delicious sauce and a little curl of cheese on top. And I'm sorry, it's dinner time and I don't see any food out here, but it was exquisite. So if you ever wander down there, I'm sure you have your own favorite restaurants, that was divine. So now that we're thinking about food and all the things that maybe we should eat, could eat, can eat, won't eat, I would like to introduce Dr. Ruliak, who's one of our gastroenterologists here at the Polyclinic, and I'm really excited to have him here. So I'm going to switch over to his slide deck.
Thank you for all coming and spending your beautiful summer-like evening here listening to what I have to say. First of all, everything you had on your vacation, you're really not allowed to eat, so I apologize. So we're gonna talk about some things that I end up talking to patients about literally every single day, and talk about sort of the 3 hottest topics in terms of digestive health and nutrition. And these include gluten, FODMAPs, and for those who don't know what FODMAPs are, you will by the end of the lecture. and the gut microbiome, which really more globally refers to probiotics, which I'm sure everybody's heard about. So, when I went into gastroenterology, I went into the field mostly because I was interested in the organ systems and the diseases, and I liked doing procedures like colonoscopy. And what I didn't realize is that literally every single day, people would come and ask me what they should eat. And after I finished my training, I realized I don't really know what they should eat, and I'm still not sure that I know what people should eat. But sometimes they end up having to go to the all-you-can't-eat buffet. So let's talk a little bit about gluten to start. And we've all heard of gluten. Pretty much everywhere you look, read, every restaurant, everything in the grocery store has the word gluten on it. So let's just talk a little bit about gluten, what we know about gluten, what we don't really know about gluten, and kind of go from there. So we'll just start basic. So gluten is a protein, and it's a protein that basically comes from certain grains. And really gluten comes pretty much exclusively from wheat, barley, and rye. Oats do not have gluten, but most oats, or at least many oats, are processed in plants where the other things are processed. So for the most part, unless your oats say that they're gluten-free, they probably have some gluten in them. And so on a molecular level, gluten is actually a combination of two proteins called gliadin and glutenin. And the reason that gluten is great is because it makes food kind of chewy and elastic. It's kind of what makes your pizza crust taste good and feel good in your mouth. Now, unfortunately, gluten results in some health-related conditions, two of which we understand very well, and one of which we're just starting to understand but don't really understand, I would say, at all yet at this point. So the first thing to talk about is a true wheat allergy. And a wheat allergy is really a very rapid response. It's an allergic response mediated by a type of antibody called IgE. Wheat allergies are fairly common in children. They're actually pretty rare in adults. So a true wheat allergy generally results in all the things that you might imagine happen when you have an allergic reaction, almost like a bee sting, wheezing and shortness of breath, and swelling and hives. And so we're not really going to talk about wheat allergy today because for the most part in adults it's very, very rare. And again, we're referring to a true wheat allergy. We are going to spend quite a bit of time talking about celiac disease because celiac disease is a gluten-related health problem that we actually understand very, very well. And then we're going to talk about gluten sensitivity. And the correct scientific term that people use for this now is non-celiac gluten sensitivity. Gluten sensitivity is also a fine term. A lot of people refer to gluten intolerance. That's probably not a very good term because the term intolerance doesn't actually refer to what most people are describing. If you think of an intolerance like lactose intolerance, what an intolerance really means is that your body can't absorb and digest something, and so the bacteria that live in your gut instead absorb and digest whatever that is, and that causes symptoms. And so, gluten intolerance is probably the wrong word. Gluten sensitivity is probably the better word, but we'll talk a lot about that too. So let's talk about celiac disease. Does anybody here have celiac disease and want to fess up? So, okay. It wouldn't be surprising if someone had celiac disease. So another term for celiac disease is gluten-sensitive enteropathy, and it's a consequence of ingesting certain grain products. And it's a pretty common disease, and depending on which population you look at, it can be as common as 1% or 1 in 100 people to as little as 1 in 300. The correct estimates are probably a little closer to 1% of people who may have celiac disease in the United States. And there's quite a bit of racial and geographic variation. So celiac disease tends to be more common in people of white Northern European ancestry or from the British Isles. Interestingly, there is a huge age range of presentation of celiac disease. So classically, when we went to medical school, we learned that celiac disease was this disease that presented in infancy or childhood, and children became horribly malnourished. But in reality, celiac disease can present at any age. I actually have diagnosed one person in her 80s with celiac disease. So why it presents at different ages, it's hard to know for sure. I don't think anybody really knows the answer to that. We do know that we still underdiagnose celiac disease, meaning there's lots of people running around with celiac disease that don't know that they have it. I think we're getting better at looking for it, and it's so easy to test for that there's really no excuse for us to miss it, but it gets missed. And as a result of that, most patients have had symptoms for a long time before they actually get diagnosed with celiac disease. One study suggested that most patients, on average, had symptoms for about 8 years before somebody actually came up with the diagnosis. So this is a busy slide. We're not going to spend a whole lot of time on it, but mostly it's to point out that we actually completely understand what happens to people with celiac disease and why they have this problem. And really, celiac disease is more an autoimmune disease that has to do with an abnormal immune response that happens in the gut in response to gluten. So I'll walk you through this. You can fall asleep for a moment if you want. This is probably not terribly important. This is a diagram, and these are basically the cells that line the small intestine. This is the inside of the small intestine, and then this schematic is kind of under the surface and in the tissues of the small intestine wall. And so what happens when someone has celiac disease is that there's gluten that is in the inside of the small intestine. The gluten gets transported across the small intestine cells and basically gets grabbed by cells in the immune system. One thing that's interesting is there's actually a type of molecule on the surface of one of the immune cells called antigen-presenting cells called an HLA-DQ molecule. And this is actually genetic, meaning some people have a certain form of this molecule that can bind to gluten and lead to this problem, and other people don't. So that's the basis for one of the tests that we can use to kind of rule out celiac disease. But there is some genetic variation in who has this particular molecule. But basically what happens is that this thing called an antigen-presenting cell grabs the gliadin and it recruits its friends in the immune system. And as a result, what happens is that certain antibodies are produced. These have names: anti-gliadin, anti-endometrial. Anyone who's ever been tested for celiac disease has probably had a blood test for this one called tissue transglutaminase. And basically what happens is that then all these antibodies rev up the immune system, and the immune system gets angry at the cells that line the wall of the small intestine. So it's not actually really the gluten that does the damage to the intestine wall. It's actually a person's own immune system that gets triggered by the gluten. So I show this not because I think you guys are interested in the basic science of celiac disease, but mostly to show you that over the past 50 years, really, this has been figured out. So it's taken a long time to go from, yeah, we noticed that these people have this terrible disease that happens from gluten, to, aha, we actually understand what it means. So the consequences of celiac disease clinically are shown here. So if you were to take a biopsy of someone's small intestine and look at it under a microscope, you see these things called villi. Villi are these finger-like projections along the surface of the small intestine. And the reason they're there is because you might imagine that the more surface area there is, the greater absorption and digestion that can occur. So what happens when someone has celiac disease is after all those molecular events that we looked at happen, there's a lot of inflammation, and over time these villi get shorter and shorter and shorter until they get like this, where basically they disappear. And so if you think about it, it makes sense why a lot of the symptoms of celiac disease occur. So instead of having all this surface area to absorb nutrients, that surface area is dramatically reduced, and so people with celiac disease don't absorb things. And when you don't absorb things, then the bacteria that live in the gut have the chance to absorb them or to ferment them and cause symptoms. And patients will malabsorb and get diarrhea and pain and bloating and all the things that people with celiac disease typically present with. So it all makes perfect sense, really. There are lots of different ways to diagnose celiac disease. Taking a biopsy of the small intestine with an upper endoscopy is really the gold standard. And I think, for the most part, I think most gastroenterologists still think that needs to be done. I had alluded to the fact that there are blood tests that you can do, which are very accurate. So in particular, these antibodies against the thing called tissue transglutaminase they're inexpensive, and they're very accurate, meaning they're greater than 95% accurate in ruling in or ruling out celiac disease. There are some other antibodies that can be done. Now, one thing that comes up in practice quite a bit is that I had pointed out to you that genetic variation in terms of who has this particular molecule on the surface of antigen-presenting cells to grab the gluten. So we often see patients who come to see us who say, well, you know what, I haven't had gluten in 5 years and I feel great, but can you tell me if I have celiac disease? And the answer is, it's really hard because all of the changes of celiac disease basically go away on a gluten-free diet. The antibodies in the blood go away, the villi grow back and look normal on biopsies, and so the answer is it's very hard to test people on a gluten-free diet to figure out whether they have celiac disease or not. There is this genetic test where you can test for that molecule. The problem is the majority of the population actually has that molecule, so the test is only helpful if it's negative in ruling out celiac disease, but that only helps you in a small minority of patients. So for the most part, if you're on a gluten-free diet, it's going to be hard to know if you have celiac disease or not. Many would argue maybe it doesn't matter if you feel good and you're happy on your gluten-free diet. Who cares? So, this diagram gets shown a lot and basically refers to the fact that most celiac disease is undiagnosed. So if we think about the people that truly have celiac disease, these are people who have an abnormal biopsy of their duodenum. All those fingers, those villi are gone. And it's probably only a small percentage of them that have symptoms and that come to clinical attention. But there's probably lots of other people walking around with celiac disease who either have minimal symptoms or just haven't come to medical attention. There's a whole other set of patients that confuse us, and these are people who have abnormal antibody tests, but when you do an endoscopy and you take biopsies, the villi are actually normal. And the thinking is that these are people who may someday develop celiac disease, but who don't seem to have it now. I did forget to mention this is informal, so if anybody has questions and wants to interrupt me, go for it at any point. So these are some pictures of sort of the classic textbook description of what happens in celiac disease. So these are children who are born with bad celiac disease. And basically what happens to them, these are the two forms of malnutrition. This one's called kwashiorkor, which is basically a protein malnutrition state. And then this is called marasmus, which is a calories malnutrition state. And these are, of course, very shocking pictures. And you almost say, well, gosh, how did these kids get to this point? But the miraculous thing about this disease is that if you take gluten away, these kids will become totally normal. They'll catch up in their growth and everything will go back to normal. So, this can be a big deal. But I think, the reason that we underdiagnose celiac disease is because I think a lot of doctors have this in their head as this is what celiac disease is. But it's, at least for most patients that have celiac disease, it's not that. So the most common symptoms of celiac disease are chronic or recurring diarrhea, bloating or distension, loss of appetite. Oftentimes this can progress to weight loss and pain, but really almost any digestive symptom can be a manifestation of celiac disease. Sometimes people come in with vomiting or constipation, and that doesn't really make any sense at all why celiac disease would lead to constipation, but it happens. And if people are moody, and you'd be moody too, I guess, if you had this problem. There is a classic skin rash that I just showed you a picture of called Dermatitis herpetiformis, and it's actually a rash that usually occurs on the forearms and the elbows, and basically looks like this. And sometimes patients with celiac disease present with this as their own manifestation. And so why do we care if someone has celiac disease? And the real reason is that if you find it, you can treat it, and people can be normal and healthy and feel great. And if you miss it, all sorts of things can happen. So in pediatrics, children can end up with short stature. There's this rash we talked about, dental enamel problems, mouth ulcers, fertility problems. A big one in adults is osteoporosis. So celiac disease is actually a very important cause of osteoporosis. And so probably worth anybody who has osteoporosis doing a blood test for it.
Now, is that because of poor vitamin D metabolism, or is there another?
It's probably both calcium and vitamin D.
Calcium.
I think it's both. Don't quote me on that. I don't totally recall. There are some very rare neurological diseases that can occur as a result of this, and extremely rare, but really bad is that sometimes patients can get something called intestinal lymphoma, which is basically a type of cancer of the small intestine. And this is usually what I use to threaten patients with who have celiac disease and won't adhere to their gluten-free diet. But I have never seen a case in 15 years of practice. But. So the interesting thing is that celiac disease is actually becoming more common. And you might say, well, maybe that's just because we're getting better at diagnosing it and better at looking for it. And well, that is true, but it's interesting because there was a study done where they actually took pooled blood from military recruits from the 30s and 40s and did celiac disease blood testing, and then got some comparable military recruits from today, and there's actually been a significant increase in the proportion of military recruits who seem to have celiac disease. We don't know why that is. I mean, so one of the hypotheses is this thing called the hygiene hypothesis. So celiac disease is basically an autoimmune disease, and lots of autoimmune diseases are becoming more common. Crohn's disease, asthma. And so the thinking is that maybe part of the issue is that we live in a society now that's too clean, and our immune systems are basically kind of weak and prone to things. So there's some thought that maybe the fact that all the food we eat is processed and junk in a lot of ways may play some role in it. There was a theory that somehow wheat actually has changed over time in terms of the way that it's been bred and such, but there really hasn't been a whole lot of evidence for that. So I think the take-home point, we don't know why celiac disease is more common now than it was 50 years ago, but it seems to be the case. So as we talked about, the estimates for how common celiac disease is in the population vary, but this was a pretty good study down in, I think this was in Minnesota, and they found that 1 in 133 people in the study had celiac disease. So this is not a rare disease. It does run in families. So oftentimes when one family member gets diagnosed, I'll see the 3 siblings all within the same week in a panic. So the reality is that first-degree relatives, parents, children, siblings, have a risk of maybe 1 in 20 of getting celiac disease. So still the majority of relatives are not going to get this. Usually we'll offer screening because it's simple enough to do it. It's a big deal. So there is only one treatment for celiac disease, and that is strict adherence to a gluten-free diet. I really think, I'm not a nutritionist. I know a little bit about nutrition, but nowhere in the ballpark of a nutritionist. And so, I feel like every patient with celiac disease really needs to sit down with a nutritionist and spend lots of time talking about this. I underline strict because the thing about celiac disease is it's an all or none phenomenon. Meaning a tiny bit of gluten is just as bad as a whole bunch of gluten. Because remember, the immune system is actually the thing that causes the problem. So a little bit of gluten triggers the problem just as much as a lot. So really the key is no gluten at all. This used to be miserable for patients. 20 years ago, if you wanted to have bread, you had to go get your own rice flour and figure out how to bake it and that kind of thing. So I guess the one good thing, there's probably a lot of good things, but one of the good things about the gluten-free revolution is that people with celiac disease actually can find things to eat. They can go out to restaurants, they can buy a TV dinner. And so, that's been pretty good. Now, gluten-free foods clearly cost more, and that's an issue for a lot of patients. It's a medical problem, but health insurance is certainly not going to help cover gluten-free foods. There are actually some medicines that are being looked at. There's actually a medicine right now that's in clinical trials, and the idea is that it actually blocks gluten from sort of getting across the intestinal border. Mostly it's being studied as something patients with celiac disease can have in the event that they ingest gluten inadvertently, but it's not clinically available yet. So I won't spend a lot of time talking about gluten-free. I suspect probably a lot of people know what gluten-free means, but gluten's in a lot of places. The big 3 are wheat, barley, and rye. And what's kind of amazing to me is that, wheat has a lot of names, not just wheat. So it's not just wheat flour and all-purpose flour, but all these things, durum, and most of these things I can't even pronounce, seitan, bulgur, couscous. So if you really want to avoid gluten, that's why it's helpful to meet with a nutritionist, because it's tricky. Now granted, nutrition labels are improving, but they are far from perfect. So natural foods that you can eat that are gluten-free are things like salads, fruits, vegetables, dairy products, meat, fish, poultry. And there are now lots of pastas and breads that are gluten-free. And if they're labeled gluten-free, for the most part, and the Food and Drug Administration has kind of mandated standards for gluten-free. So those are actually pretty good now, and that was not the case even 5 years ago. Gluten is hidden in a lot of places. Soy sauce is a big one, but I mean really just anywhere you could imagine. So it's tricky to be gluten-free. And a lot of times we'll see patients with celiac disease who kind of aren't getting better. And sometimes the issue is that there's cross-contamination from somewhere. Kids, I mean, I don't see kids, but Play-Doh, crayons, I mean, can be certain, and kids actually eat this stuff that I can vouch for. And certain types of makeup have gluten and can get ingested. Medications are actually a big one, and there are lots and lots of medications that have gluten in them. And so there are websites and phone numbers that you can use to check this. If you go to the Bartels and ask the pharmacist, they won't know, but usually they can help find out. So this lady says she's cutting back on gluten, but hasn't quit completely. Can she have gluten on the side? And the answer is, if you have celiac disease, no. So let's talk a little bit about the gluten-free movement. So, 10 years ago, gluten wasn't talked about a whole lot. You certainly couldn't go to a pizzeria and order a gluten-free pizza. And, there's a lot to the gluten-free movement, and I don't need to be a skeptic, but I do have to point out that it's expected that gluten-free products are probably going to exceed $15 billion per year by the year 2016. So, don't kid yourself, this is big business, and food companies think about that. There are surveys that say that about a third of Americans are trying to eliminate gluten from their diet now. I don't know why that is. I mean, certainly cutting carbs can help you lose weight, so maybe a portion of it is that. But I think part of the issue is that gluten has kind of been blamed for lots of health issues. And the problem is there's not a lot of evidence that gluten causes all the health issues that it's been blamed for. So that kind of brings us to this thing called gluten sensitivity. And you may be a little disappointed by the time I get to the end of this section of the talk, because the reality is we just really don't know anything about this condition. We know a little bit, but in terms of the elegant detail that I showed you for celiac disease, we are nowhere even close. And so, again, this condition is sometimes referred to as gluten intolerance or gluten sensitivity. And the real reality is we don't understand the biology. And so as a result, a lot of scientists and physicians say, oh, this doesn't exist, this is all in people's heads. And that may be, but there was a time when we thought the world was flat too. So it may just be that we're not smart enough to understand this. So, I don't find that it's helpful to kind of poo-poo patients and say, oh, this doesn't exist and you're fine. But I think we also have to be honest and say, we don't understand this. So there have actually been, there's a lot more research over the last 5 years into this topic than there was before, when there was basically none. And so there have actually been some consensus conferences, and when there's a new disease, you kind of come up with a definition. So the definition is a clinical entity induced by the ingestion of gluten leading to intestinal and extraintestinal symptoms, and we'll talk about that resolves when the gluten-containing foodstuff is eliminated from the diet. And the other part of the diagnosis is that you have to make sure these people do not have celiac disease or wheat allergy. So that's the definition of this condition in 2015. So what do we know about gluten sensitivity? Well, I think a lot of the interest in gluten sensitivity actually started with a study that was published in 2007. And this was not a big study. It had 41 patients in it. These were patients who had irritable bowel syndrome, and we'll talk more about irritable bowel syndrome in a second. These were irritable bowel syndrome with diarrhea patients. And in these patients, they all had duodenal biopsies. None of them had celiac disease. Some of them did actually have positive celiac disease antibodies, but that shouldn't really matter, because if the duodenal biopsies are normal, you don't have celiac disease. They took these patients, there's no control group, so there was not some patients that were on a gluten-containing diet and some patients that will want a gluten-free diet. But interestingly, 30% of the patients felt a lot better off gluten. And this is not the only study like this. There actually are 3 or 4 studies that all kind of show the same thing. So, that suggests that there's got to be something to the gluten. What that something is, I think we don't know. There was a more recent study where they actually took patients who were felt to have gluten sensitivity on the basis of the definition that we used. And they actually randomized some of them to get gluten and some of them not to get gluten. And interestingly, more people felt worse when the gluten was reintroduced. So again, maybe there's something there. Now we will talk about FODMAPs. Part of these studies are tricky, and any study of diets is tricky because you're not just changing one variable, you're changing multiple variables. It's not like you can just remove the gluten and what people eat is all the same. And so there are some who would say gluten is technically a FODMAP. I'll talk about what that is in a second, or wheat. And so there are some people who say, you know what, this is all just FODMAPs and this has nothing to do with the gluten. Maybe, but I guess we don't know that. And one other observation that's been fairly prominent in all the studies of this is that people who seem to have this gluten sensitivity condition seem to have psychological and or sort of mental changes that seem to vary with the gluten. And that includes things like fatigue, poor attention, a lot of patients call it brain fog. And so what that means is anybody's guess. So just to kind of summarize the differences, celiac disease is autoimmune. Gluten sensitivity, as far as we can tell, is not. Celiac disease has positive blood antibody tests. We have no way to test for gluten sensitivity. Duodenal biopsies are abnormal in this disease, normal in this disease. Lots of bad things can happen in celiac disease. I guess the good thing is serious medical complications, osteoporosis or iron deficiency, do not appear to occur with gluten sensitivity, although quality of life is obviously a big deal, and while it's not technically a complication, it's a big deal. And so we don't know enough about this condition. So why do patients who feel better on a gluten-free diet? Well, some of them might have celiac disease and we didn't bother to look. Some might have this gluten sensitivity condition that we don't totally understand. A gluten-free diet is also a lower FODMAP diet. We're going to talk about FODMAPs next, but it's not a low FODMAP diet, but it's lower than FODMAPs. Now maybe, a gluten-free diet is a much healthier diet because it's, you can't eat McDonald's and all sorts of junk and be gluten-free. So there are some people who say, you know why these people feel better? It's because they don't eat processed food. Maybe that's true. It's been shown that people who eat gluten-free generally eat less, so maybe that's part of the reason. And just like anything we do, there's always a possibility for a placebo effect. So maybe these people just feel better because they're doing something. So patients come to me all the time and say, well, I'm thinking about going gluten-free. What do you think? And there was a point in time when I was sort of dogmatic. I said, well, if you don't have celiac disease, that's crazy. And that doesn't help anybody because patients don't like that. And quite honestly, we don't know everything about gluten in the human body. So the things I tell them are, you know what, please get tested for celiac disease before you do it, because otherwise it's very difficult to figure out whether you have it after the fact. And it's important to know if you have celiac disease, because if you have celiac disease, the stakes are high. You have to be on a strict gluten-free diet, period. Otherwise, bad things can happen to you. If you don't have celiac disease, you can dabble with the gluten-free diet, and if you get sick of it, you can stop. I do tell patients that, you know what, your digestive symptoms, and again, they're mostly coming to see me for digestive symptoms, not nutrition advice, but there's maybe a 30% chance if you have IBS that you're going to feel better on a gluten-free diet. So I'm honest and say maybe it's not the gluten, but who knows. You might actually lose weight, and a lot of patients who go on a gluten-free diet do lose weight. Patients with celiac disease often gain weight when they go on a gluten-free diet, but that varies a little bit. So, but for some patients, that's an important motivator. And I think one other thing that's important to remember is that it's not easy. It's easier than it used to be, but it's still not easy. And so gluten-free diet is hard work. So let's switch gears. So I've kind of been alluding to irritable bowel syndrome. And so let's talk about what irritable bowel syndrome is. I won't ask if anyone in the room has irritable bowel syndrome, because that might be embarrassing. So irritable bowel syndrome is what we consider a functional disorder of the gastrointestinal tract. And what that basically means is that some might take it to mean that we don't know what it is. But really, we think it has to do more with the way that the digestive tract is functioning, not with some sort of structural abnormality, a blockage or a tumor or an ulcer. So it really has more to do with the way that the digestive tract is working. And really, how we diagnose irritable bowel syndrome is with 3 simple criteria. People have to have pain, they have to have abnormal bowel movements, and again, that can be diarrhea or constipation, or some lucky patients get both. And there has to be the absence of an organic disease, meaning we have to rule out celiac disease, we have to rule out Crohn's disease, and other things that can cause these same kinds of symptoms. So it's interesting, there was a study done that basically showed that 15% of Americans meet the clinical criteria for irritable bowel syndrome. And these people are not all seeking medical attention, but basically this is a very common problem. And there actually have been some studies that suggest that irritable bowel syndrome is the 2nd most common cause for people missing work behind the common cold. So it's a big deal. And the frustrating part of this diagnosis for patients and doctors is that we don't know what causes it. And 30 years ago, people just thought this was some sort of mental or nervous condition, spastic colon, or whatever you want to call it. And we now know that's not true at all. There are biologic abnormalities that can be found in patients with IBS that are different than people who don't have IBS. The real reason we don't understand this condition is probably because it's not one condition. It's probably a bunch of diseases that we lump together based on similar symptoms. And as we get smarter, we're probably going to get better at figuring out who has what in this category. And when we do, we're going to get better at treating them. Because right now, there's lots of different treatments for irritable bowel syndrome. And treatment is by trial and error. And that's because we don't really know when someone comes to see us what they actually have. But I think one of the most important and empowering things that I tell patients with irritable bowel syndrome is, you're not crazy, you have a real thing. We know more about your real thing now than we did 10 years ago, but we don't know enough for me to figure out exactly what you need today. So it's often trial and error. I like this one. I'm afraid your irritable bowel syndrome has progressed. You now have furious and vindictive bowel syndrome. So that brings me to FODMAPs. So this is, in my opinion, literally the worst mnemonic ever because I cannot remember it. I talk to patients about it every day and I can never get it all out in one sentence. But basically what it stands for is fermentable oligo, di and monosaccharides, and polyols. So it's a terrible mnemonic. So it's much better to, let's just go with FODMAPs. But basically what all these things are is they are carbohydrates. And basically carbohydrates are sugars that have sort of varying lengths when you look at them on a molecular level. So these are short chain carbohydrates. They tend to not get absorbed very well through our digestive tract. And so they're osmotically active in the intestinal lumen, which means they can drag water from sort of the tissues in the bloodstream into the inside of the lumen. And that can result in symptoms like diarrhea and bloating and pain. And in addition, FODMAPs can be fermented by the bacteria that live in the gut. And so that can also result in abdominal bloating and pain. And so this is a fairly new thing, really, in terms of people thinking about it as a treatment for irritable bowel syndrome. So let's just go over, and again, my disclaimer, not a nutritionist, but let's talk about these. So fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So lots of foods over here. A few highlights: wheat, barley, and rye, which are sources of gluten, are also FODMAPs. There's lots of things here. Lactose is a big one, so dairy products are on a low FODMAP diet. certain types of fruits and some vegetables, and then also a lot of these artificial sweeteners and things, sucralose, are FODMAPs. So I don't have any of this in my brain. I hand out, I give patients a handout. There's a great one that you can Google. If you type in Stanford and FODMAP, they have probably the best handout I've seen.
And I have copies in my office if anybody ever wants one.
The Stanford one?
Yeah.
It's good.
Yeah.
Yeah, it's really good. So, you know, a lot of patients, you know, come to me and they say, oh, this is crazy. Why did you come up with this hypothesis? Show me, why in the world would I do this? This is hard, and why? And the answer is, well, you know what? We actually have some evidence that this works in certain patients with irritable bowel syndrome. And this is a busy slide, but basically, you know, on this axis is a rating scale where basically you ask patients, okay, how do you feel in general in terms of your digestive symptoms? High is bad, low is good. So they took some patients with irritable bowel syndrome, and this was in Australia, and they took some patients who were normal. And as you might expect, before they introduced the diet, patients with irritable bowel syndrome felt a lot worse than normal patients. And they randomized these people. I don't know that you can truly randomize somebody because you can notice, oh, this is not my normal diet. But they put these patients on the typical Australian diet, I don't know what that is, shrimp on the Barbie, versus a low FODMAP diet. And healthy controls, of course, felt the same on either. Very significant difference in patients who have irritable bowel syndrome. So, you know, this actually was published in a very good journal and was kind of, there aren't a lot of studies like this in irritable bowel syndrome, but this is pretty landmark evidence that suggests, hey, this is a reasonable treatment. The issue is it's a difficult treatment. So, cutting FODMAPs out of your diet can be quite helpful in a subset of patients with irritable bowel syndrome. This is probably not a sustainable long-term diet. I mean, certainly, even in the short term, it's pretty easy to get malnourished with cutting all these things out. So generally the recommendations, if you're going to try this, is that you probably should, you can go ahead and go with a strict low FODMAP diet, but you probably should only do that for 6 or 8 weeks. And then, via the process of trial and error, reintroduce foods and see what you can eat and what you can't. But this is not easy, this is difficult. And so, you know, ideally this should be done under the direction of a nutritionist. Insurance, I have not had any luck getting insurance to pay for patients to meet with a nutritionist to talk about a low FODMAP diet. That hopefully will change based on the fact that there's no study, but not so far. All right, so let's wrap up by talking about probiotics. Anybody here take probiotics? You like them? Sure, why not? So let's talk about what probiotics are. So probiotics are live microorganisms. They can be bacteria or yeast, and which, when administered in adequate amounts, confer some health benefit to the host. So that's a very broad definition. The real reason that we often recommend probiotics, or that patients are taking probiotics, or non-patients taking probiotics, is to somehow alter the gut microbiome. So living inside of each one of us here in the room now are literally billions and billions of bacteria. And, you know, from hundreds of years of medical science, nobody thought that these bacteria played any role other than they were just there. And over the last 15 or 20 years, it's actually become apparent that there's more to these bacteria than just some bugs that live in our gut. And they probably play a big role in health. But what those roles are, we're still learning. So the thing about this is that this is incredibly complex. And if you sat down and read research articles, and there's lots of research on this, your head would hurt because it's very complicated, and quite honestly, most of the basic science research goes over my head. So here you go, special offer, buy 4 million, get 1 free. So what we know that the gut microbiome is involved in is it plays a role in digestion. The bacteria that live in your gut help to produce certain vitamins, vitamin K being the main example. In babies and fetuses, gut actually matures as a function of the types of bacteria that live there. The bugs in the gut stimulate our immune system, and so that is part of the whole hypothesis about why autoimmune diseases may be becoming more common, because the bugs in our gut are less diverse. They play a role in things moving through us, antibiotic resistance, and lots more things. And so if you go and try to buy a probiotic, first of all, you'll face a dizzying array of choices, and you'll see all sorts of different bacteria. And they basically fall into two main species. The two most common species that you see in probiotics are lactobacillus and bifidobacterium. But there's lots of others. Streptococcus, lactococcus, Saccharomyces boulardii is actually kind of an interesting one that I'll tell you about. So we do have some evidence that probiotics can be useful for certain conditions. This is kind of the thing where the drug has come out before the science to explain it, meaning we're sort of manipulating the gut microbiome, although we don't really have any clue what we're doing and why. So it's really just, it's kind of a Wild West a little bit. Try things and see what happens. And at least in certain conditions, probiotics have actually been studied and shown to be effective. So one thing that, probably the thing that's been most studied is actually infectious diarrhea. So go to Mexico, you get a bug. You go to preschool and pick up some virus. And probiotics have actually been shown to shorten the duration of infectious diarrhea. Not by a lot, by a day or two, but more than placebo. The most common ones studied for this use were Lactobacillus GG, which is culturelle, and Saccharomyces boulardii, which is Floristor, and we'll go over those at the end. So C. diff, who's heard of C. diff? You've heard of C. diff because it's the disease that's cured with the stool transplant. But C. diff is a big problem. And basically, it's a colon bacteria infection that's caused by alteration in the normal gut flora, usually caused by an antibiotic. So that one antibiotic that I mentioned, Saccharomyces boulardii, or Floristor, has actually been studied in people who had very difficult to treat or refractory or recurrent Clostridium difficile infections and have been shown to be effective. So I often use that in people who have recurrent episodes of C. diff. Probiotics have been studied in irritable bowel syndrome, and they have been shown to be helpful in a subset of patients with irritable bowel syndrome. There's something called pouchitis that probably not too interested in. Pouchitis has to do with people who had their colon removed for one reason or another, and they can get this bad inflammation condition in the what's called the ileal pouch, which is sort of the new reservoir that a surgeon makes when they take your colon out. So there are medical diseases that probiotics have been shown to be effective in. Now, most people don't take probiotics for these medical diseases. Most people take probiotics to feel better. Probably a lot of people who are taking those probiotics have irritable bowel syndrome, whether they know it or not. And so it's a very reasonable thing to do. So then there are lots of other studies of things that probiotics might help, and the evidence is, I think, less good in these conditions. But there have been some studies of probiotics in mild Crohn's disease and mild ulcerative colitis that showed some promise. Some patients with allergies and eczema may improve. It's been studied in cholesterol, Helicobacter H. pylori infection, which is a stomach infection, lactose intolerance, yeast infections, bacterial vaginosis. So there's a long list of things that probiotics could help with, but there's less evidence for these. So this is the million-dollar question that I get asked every day. Well, which probiotic should I take? And I think that the God's honest truth is anyone who tells you that they know which probiotic is best is lying to you, because we don't know, and we just don't know enough. I often tell patients that if you like yogurt, do yogurt. Yogurt is an excellent probiotic as long as it's a yogurt that has live bacteria in it. And so that's Greek yogurt or Dan Active. It's not the Tillamook or the Dannon or the Yoplait where there's nothing. So there's nothing wrong with using yogurt, and you know what, if you like yogurt, that might be the best way to go. It's probably the most economical, and it tastes better. One other thing to tell patients is that people often worry, well, gosh, I'm putting all these bacteria in my body. What if something happens to me? And the reality is there is really no evidence that in a person who has a normal immune system, that anything bad can happen from probiotics. There are some very rare case reports of people getting bacteria in their bloodstream or unusual infections in people who've had an organ transplant. So if you've had a heart transplant, maybe probiotics aren't that important for you. One other thing that's kind of interesting is that you have to be careful when you buy probiotics because you may not actually be getting probiotics in what you're buying. So there was a website that actually tested 25 of the most popular probiotic products on the market. 19 of these were marketed for everybody, 3 were specifically for children, and 3 were yogurt preparation. And when you go to buy a probiotic, some of them will tell you how much is in there when you're consuming the probiotic. A lot of them will only tell you how many bacteria were in there when they made the product, and the bacteria don't necessarily live forever. And so, interestingly, 8 of these 25 brands contain less than 1% of the amount of probiotics of bacteria that they expected. And the normal kind of minimum is probably about 1 billion of whatever bacteria you're planning to take. Fortunately, none of these were contaminated with bad things, so safe, but I'd be kind of mad if I spent money and only got less than 1% of what I was supposed to be getting. So when patients ask me which probiotic to take, I usually tell them, I usually recommend sort of the mainstream brands because I think that the odds are better that a product that's made by, for instance, Procter & Gamble will probably have in it what they say they'll have in it, because otherwise they'll be on 60 Minutes, and that would be bad for Procter & Gamble. But, I mean, these are the sort of the big 4. And Culturelle is lactobacillus. That was the one that was studied extensively in infectious diarrhea. Align has bifidobacterium and available at Costco, pretty cheap. Florastor is the one that's been studied mostly in C. diff infection, and so, and then there's this one called VSL number 3 that's pretty expensive, but also fairly popular. And how much? Again, anyone who tells you they know is lying, but most authorities say you should try to get 1 billion organisms a day.
I have a question.
Yeah, absolutely.
Back on that, could you take Culturelle and Align, and then you've got 2 different ones going on, and would that be a benefit?
So you certainly could do that. And in fact, so for instance, VSL number 3 actually has 3 different kinds of bacteria in it. So so a lot of these are just one bacteria, but there are also lots of combination probiotics on the market. And could that be a benefit? Maybe, but we just don't know. So you certainly could take more than one. I don't think there'd be any risk in that. And the issue is that these are not that inexpensive either. So it's costly after a while. All right, so I'm going to wrap it up with some take-home points. And when I finished making this talk, I kind of came to the conclusion that really, I probably raised more questions than answers for you today in talking about gluten and FODMAPs and probiotics. Celiac disease is a well-understood entity. We know the biology. It took us 50 years to do that. Other patients who don't have celiac disease may feel better on a gluten-free diet, and I don't know why, but hopefully over time we will learn more about this thing called gluten sensitivity. In someone who has IBS, a low FODMAP diet can certainly be helpful, and it's worth a try, and I recommend it a fair bit for the right patients, but there are some people that are not going to do this. Quite honestly, I don't know that I would be able to do that. But, and lastly, probiotics can be helpful for lots of things, including digestive conditions, but we have a lot more to learn. So it's sort of dealer's choice. So wrap up. You don't need a colonoscopy, but I'm sending you one. It's a colonoscopy. All right, and that's all I have. Does anybody have any questions? No?
So someone who has celiac, and they've just been diagnosed, and they start a gluten-free diet. What's the average time frame before they feel good? Or before their gut heals?
It varies a little, but it's pretty amazing that people actually feel much better, much quicker than I would expect. In a week or 2, people feel significantly better. The antibody levels often are gone by 3 months. Most people say, we check the antibody levels at 6 months to make sure that people are being compliant and that sort of thing. But it's actually pretty amazing that the clinical improvement happens more quickly than I might expect the gut to become normal. But people feel better fast, often.
And I guess same question for the non-celiac gluten sensitivity. It's hard to answer, I'm sure, but is there that same rapid response if they're going to have a response, or is that totally?
You know, so it's interesting. It's a spectrum. So if you look at wheat allergy on one end of the spectrum and celiac disease on the other, gluten sensitivity is kind of in the middle. Meaning people who have a wheat allergy, literally within minutes of ingesting wheat, they will have this terrible allergic reaction. Patients with celiac disease, a lot of times, I mean, they sort of tell me, I can tell I got gluten, I knew it right away. But most of the studies suggest that it actually takes probably a week or two of gluten ingestion for someone with celiac disease to start feeling bad. People with gluten sensitivity are on the faster end. I mean, they feel worse quicker, and likewise, probably feel better quicker. We may cut out the gluten, but not that we know for sure. Yeah.
So somebody with a normal system, do probiotics have any value?
Not, quite honestly, no, not that we know. I mean, I don't know if I have a normal system, but I don't take probiotics. But I certainly have no problem recommending them. I don't know that I would take them unless I had some symptom that I was trying to make better. So I don't think there's a good rationale that everybody should be taking their probiotics every day. Yeah.
I've been eating gluten-free for a couple of years. I have to eat very strictly gluten-free, depending on as strict as I can. I had some questions about FODMAP, and because there seems to be a little bit of disconnect in the gluten-free, actually I eat grain-free, doing what I wanted to do. And so I think it answered a lot of my questions. Your talk today, I really appreciate it.
Gluten's like a small part of FODMAP, but that's part
Yeah,
of the trickiness is that there's overlap, and that's what makes the studies hard to interpret.
Something just doesn't quite fit quite right, not miraculously perfect.
So there's probably more than one for a lot of patients with digestive.
Maybe I'm
There's probably more than
and
one.
gluten.
Yeah, wouldn't that be great?
Yeah.
Or maybe you're just FODMAP. I don't know.
Yeah. But it's first, certainly I've been trying for 6 weeks.
Sure. Great. Sure.
Do we have all this stuff in us, or we're just adding more when we put in the probiotics, or?
Yes, so we all the things that are in these probiotic preparations are bacteria that you can find in your gut in certain amounts. And so the idea is adding more. And there may, in some cases, there's maybe some very loose scientific rationale for why, but as I said, it's kind of a little bit like the Wild West, and it's sort of just, let's try this and see what happens. And so, there you have it. Yeah.
Your feelings on taking probiotics when you're taking antibiotics?
So this actually comes up a lot, because intuitively it makes sense if this thing, C. diff infection, is bad, and it usually happens as a result of getting a course of antibiotics. So, but one time I might actually consider using a probiotic would be after a course of antibiotics. So probably doesn't make sense to take them both together. Now it's complicated because if the antibiotic you're taking is not active against the probiotic, then maybe it doesn't matter. But usually I tell patients that, hey, if you're going to use a probiotic after, to kind of combat problems related to antibiotics, it's probably better to wait until the last day or two of the antibiotics and then start your probiotics. There's no harm in taking them together, except you're probably wasting your probiotic money. Yeah.
For someone with Crohn's, would you recommend the FODMAP diet?
Well, I mean, I guess the answer is you could, but the issue is that if someone has Crohn's and they have symptoms, you need to be very sure first that their symptoms are not from untreated Crohn's, because the FODMAP is not addressing the problem of Crohn's, which is uncontrolled inflammation. And so if someone has terrible Crohn's and they go on a low FODMAP diet, they'll probably feel better. But the problem is you're not really addressing the problem, which is the untreated Crohn's, which can lead to all sorts of bad things. So, people might feel better on a low FODMAP diet. We used to, 20 years ago, for people with Crohn's disease, we bring them into the hospital and we put them on what's called bowel rest. We wouldn't feed them anything. And we give them intravenous nutrition or what have you. a lot of them felt better, but we've since learned it's not because we were actually making their Crohn's that much better. It was because if you're not putting anything through the system, the symptoms are less.
So how do you treat someone with Crohn's today?
There's a huge range of different medications that can range from kind of mild things on one end, but most of the treatment of Crohn's disease, it's immune suppression medicines. Good. All right, well, thank you very much. You can all go and have some low FODMAP gluten.
Thank you very much. Have a great evening, everybody. Thanks for coming. Enjoy the sun.